My name is Adam Rodman. I'm a general internal medicine physician at Beth Israel Deaconess Medical Center in Boston, and I'm an assistant professor at Harvard Medical School. And I study how humans, the doctors, and artificial intelligence can collaborate to take better care of patients. It is very tricky to a priori understand the best way for human clinicians and AI to collaborate with one another. I think that if you intuitively asked most people, they would respond with, what's called the fundamental theorem of informatics. It's funny because it's probably not true, which is that just a human using an AI system, whatever that means, will be better than either the human alone or the AI system alone. A lot of research, however, has not, that hasn't happened. That actually is not what the experimental literature says. For diagnosis, for management, for interpreting radiographic images, for trying to identify breast cancer, that kind of falls apart when you test it. And it's not crazy, right? This is what we know from other fields like autonomous cars or autopilot on airplanes or industrial safety. So the ideal system for humans and AI to work together is going to be different based on the task. So what am I doing is going to be different based on the AI. But at the end of the day, what we have to focus on is, what improves patient care. And I think that's going to lead in the next 10 or 15 years to some pretty strange ways of humans and AI collaborating. So, for example, we may be in a situation where it's actually better off for the patient to start talking to an AI before a doctor is brought in to talk to them more, where the AI hands off to a doctor. There may be some situations where, you'll want the AI making the decision. And there are probably going to be some situations where you just want the human, where the AI actually decreases performance for the patient. So there's no easy answer, and it makes this field very challenging, but also very exciting. Artificial intelligence is bewildering, especially when you're talking about large language models or a lot of these foundation models, so things based on transformers, because they can be superhuman in one task and then absolutely idiotic in another. And, sometimes they'll straight up lie to you or try to gaslight you. So that's how I think about it when we're talking about medical tasks. So these transformer-based large language models are really good right now at diagnostic tasks. And it's not crazy to think why. What is diagnosis? It is identifying signs and symptoms from a patient and then trying to fit them to a disease script, often one or just a small number of diseases. Well, large language models operate similar to humans, right? Humans store information semantically in things called scripts. That's basically what large language models do. But large language models can encode so much more information, right? I'm 15 years into this, and compared to the amount of knowledge that's encoded in, say, GPT-4, I'm a tiny, tiny fraction of that. Also, if you talk about how language models are trained, they use reinforcement learning. It's really easy to reinforce a diagnosis, right? At the end of the day, there's a right diagnosis, or it's more complicated than this, but there's a right diagnosis or a wrong diagnosis. So language models show a lot of their abilities in this specific task. Now, you ask any doctor who practices, so I'm an internal medicine doctor, I do a lot more than diagnosis, right? We make a lot of management decisions under considerable uncertainty. And those decisions actually take a lot of patient context. It take a lot of understanding. It's not just reading the guidelines. It's understanding who the patient is, the context of your health system, what their goals are, and then taking the evidence and applying it to that. Language models, they actually do this reasonably well in certain situations, but certainly they have a long, long way to go. And why? Well, because there's multiple right medical decisions and there's multiple wrong medical decisions. And it's really hard to say reward a single right or a single wrong decision. And then when I make decisions, when doctors write down why they're making a diagnosis, they usually include it in the notes. So language models can train on that. When I choose to use one beta blocker over another beta blocker, I very rarely document that. In fact, the psychological literature says a lot of doctors don't even consciously think about those reasons, even if they are encoding knowledge. So all of that makes it really not impossible, but really challenging for language models to do a lot of the more nuanced medical decision making, even though they can do really impressive diagnostics. So just I'm sure you've seen those robots that can do acrobatics, but they can't pick up a bag. It's similar to language models. They can make the most impossible diagnoses that any human would miss, but they can't make very simple management decisions that a second or third year medical student could often make. For physicians that are really interested in integrating LLMs into their clinical care, I have some advice. So first of all, privacy considerations are real. Almost none of those public chatbots that you use are HIPAA compliant in any way. So do not push private patient information into a language model. Now, a lot of places have secure LLMs. We do at my institution, and many places, for example, have Copilot. So if your institution has a secure LLM, it is fine to put patient information into it. Similarly, there are now increasing number of HIPAA compliant LLMs that you can use. I know Doximity has one, and Open Evidence, which is a reference guide. Open Evidence now is also HIPAA compliant, so you could put patient protected information into it. So my general advice, other than the privacy component, is just to engage with it. LLMs are they're tricky because they seem intuitive. It's a chatbot. It seems like it's talking to you, but they have unique failure points and they have unique abilities that are not obvious. And I will tell you, the companies, when they release a new chatbot, they don't tell you what they're good at and what they're bad at. And it's not because they're malicious. They don't know. So the only way that individual clinicians can really figure out the best way for them to use an LLM is to experiment with it themselves. So I know this is intimidating, and especially if you look at the whole spectrum of people being comfortable with technology and not, this leaves a lot of people out. So I may only be speaking to maybe the 20-25% of early adopters, people who like playing around. For the rest, what I will say is that you do not need to feel that you need to use a chatbot in your clinical practice right now. The tech is powerful, and I 10 years from now, I highly doubt there's going to be a medical ChatGPT that you're typing in. These things are just going to be integrated into our workflows as they safely demonstrate the ability to improve patient care. Again, any other technology. We have been through this before in medicine. We've had many new technologies integrated. So the other piece of advice I would say is, if you don't want to do that, don't feel like you're missing out. This tech is going to get integrated. It will come. I think there's no question that it's going to come, but you don't need to be using AI decision support every single day unless you find that it's useful to yourself. 5 years from now, I don't think that medicine is going to look that different than now, though I do think we're going to start to see the signs of what human-AI collaboration might look like in the future. Part of the reason is that this is a safety-critical industry, right? We have really high standards to meet. It takes a long time to run clinical trials, and AI technology is continuing to accelerate all around the way. And because of that, regulatory systems move slow, right? Well, some of that is government dysfunction, but some of that is also just a natural conservatism about changing up things where there might be huge implications for human health. However, 5 years from now, I'll make a prediction. I think that it is going to start to become normal for patients to talk to an AI before they see a doctor or even while they are seeing a doctor, that there might be an AI that is listening in and not just writing a note, but giving advice or pulling up reference or even pending orders while they talk to that doctor. I also think that decision support, so physician-initiated decision support and second opinions, will be routine in medicine. Not necessarily for making management decisions, but certainly when we don't know what's going on, I think that physicians will increasingly rely on AI assistance for that. I do not think that in 5 years from now, we will be at the point where AI are autonomously making decisions in any domain, but I think that we'll start to see more public acceptance of this idea, and then technology and trials starting to head in this direction. So one of the biggest things that I think can make the biggest difference is actually CME. Individual hospitals aren't necessarily going to have the expertise to appropriately train people. Medical boards, I love them, but they move incredibly slow and they're incredibly conservative. And by the time they ever update their curriculum, usually it's already 5 years out of date. So CME providers, I think, play the essential role in providing that sort of timely training. I think CME is incredibly important.